Hi class, Professor Myria Evans again. This is BSC 2086, Human Anatomy and Physiology Part 2, and this is the endocrine system Part 2. So now we're going to talk a little bit more about the rest of the glands. So we went through the pituitary gland and we distinguished anterior pituitary hormones from the posterior pituitary hormones, and we understood the control that the hypothalamus has on the pituitary gland. So now we're going to talk about some other hormones and the glands in which they are secreted. Oh, look at the thyroid gland. I like it. Okay, so the thyroid gland is butterfly shape. That's there, has this isthmus is my favorite part. That's where it connects the two lobes of the thyroid gland. So you can see the isthmus, right? It kind of crosses over. And then there's follicles that cause the release of thyroglobulin, which is a protein. Now, colloid is a fluid that is there. Parafollicle cells are just that. They're peri, which means around these follicles, and those secrete calcitonin. Now, for me, I don't care about where specifically in the thyroid gland that calcitonin is released, but I need to know that you know that thyroid gland releases calcitonin, which you should know because you learned that in 2085 when we were talking about the bone chapter. Now, when we get to the pancreas, they're going to do the same thing. There are different types of cells that secrete insulin and different types of cells that secrete the glucagon. And that, again, I don't care. I just need you to know the pancreas secretes those. But when we talk about the adrenal gland, I absolutely, unequivocally need you to know for sure that the adrenal medulla is where adrenaline comes from, and that the adrenal cortex is where we get these corticotropic hormones, which we'll talk about again in this lecture. But for this one, thyroid gland, and they're giving you example calcitonin. And calcitonin, of course, tones down calcium in the blood. That's the way I like to do it. So this right here is a little isthmus. Isn't that cool? Isthmus. Anyway, so these are the two lobes of the thyroid gland, and that's the isthmus. Thyroid. All right, and then these are just the parafollicle and the follicle ones. So thyroid hormone, calcitonin, they come from different cells in the thyroid gland, but just make sure you know that thyroid hormone, which exists in two types, comes from the thyroid gland. That part's easy. And then calcitonin also comes from the thyroid gland. All right. Oh, look, thyroid hormone exists in two forms. I didn't know that. Anyway, so we have triiodothyronine is T3, and then thyroxine is T4. So T3 and T4 are both thyroid hormones. Now, the difference between these two is T3 has 3 iodine and T4 has 4. Yep, that's the major difference between the two of them. So they're iodine-containing hormones. They are amine hormones, which means they are water-soluble hormones. However, we already know that thyroid hormone acts like fat-soluble hormones, right? Or lipid-soluble hormones. That means it goes through the membrane. All right, now thyroid hormone, as you know, affects almost every single cell in the entire body, remember? So metabolic processes for every single cell in the body, that means they have a receptor for the thyroid hormone. The effects of thyroid hormone increase basal metabolic rate. So again, they affect the metabolism of every single cell that's in the body. As a result of that, then the thyroid hormone controls or regulates how almost every single cell works. Therefore, if thyroid hormone isn't working properly, then it will be and can be a problem, right, for a whole host of other things in your body. And I think most people know that. There are people who had to have their thyroid gland removed, and they're on hormone therapies, right? And then we've got to get it straight. We got to get it fixed. And unfortunately, if you have hypothyroidism, then you end up gaining a large amount of weight very, very quickly, which of course is dangerous. If you have hyperthyroidism, then you end up losing a lot of weight very, very quickly, which is also dangerous. So that thyroid hormone and the fact that it affects almost every single cell in the body, it's a big deal, right? It is a really, really big deal. Anyway, thyroid hormone helps regulate tissue growth and development, and we know that because we talked about its relationship with the growth hormone, right, earlier. It helps maintain blood pressure because it increases androgenic receptors and blood vessels. So the thyroid hormone, I'm telling you, it's a big deal. We know that the release of it is triggered by thyroid stimulating hormone, right? So we know that. And then what else is there? You don't have to know about the synthesis. Like, I'm not going to test you on that. Trust me, there's plenty to know already. All of these hormones, where they're released from and what their functions are for the endocrine system. And then we move, of course, into the respiratory system as well as this next test. It's just 2 chapters. So I'm not worried about you understanding the synthesis of the hormone, but I do need you to know that iodine is extremely important. Persons who have goiters, which are these enlargements that you see in their neck, and that's because the thyroid gland has become enlarged. This has to do with iodine deficiencies, and they will, of course, talk about that when we get to the homeostatic imbalances that are associated with, of course, not having iodine. Anyway, so you don't have to worry about the synthesis, but this part is, again, kind of cool. T3 and T4. T3 has 3 iodine, and T4 has 4 iodine, right? And that's kind of a, a big deal. All right, synthesis, of course. And then T4 can be converted into T3. All we do is, of course, take off one of the iodine. What? No way. So basically, again, with the synthesis, you don't really have to know that. But this part is kind of important, just that a visualization of T3 and T4. So obviously this is T4 because it has 4 iodine, and this is T3 and it has 3 iodine that are there. And the reality is that in order for us to attach iodine to the hormone so they can be in its structure, its actual structure, that means we have to have iodine, right? So what I will tell you is that sea salt, right, is uniodinized, and most other salt is iodinized. You can read that. Like, if you just go and you, wherever you shop, whoever salt that you buy, if it's Morton's salt or if it's, Walmart brand salt or wherever you shop at, Publix probably has their own brand of salt, whatever, it's iodinized. And that's important because you have to have iodine in order for thyroid hormone to work properly, and thyroid hormones course control, right, metabolic processes of almost every single cell in the body, right? So it's kind of a big deal. Anyway, so we have to have iodine, and a decrease in iodine is going to cause that goiter. Okay, anyway, so let's see. These are transported by proteins. So thyroxine binding globulins. Remember, we said that hormones can travel either bound to proteins or they can be free in the blood. And so these are bound to a protein. This part is just kind of interesting. Again, whenever we have to convert it into T3, right? T4 can be converted into T3, as I mentioned. We just take off an iodine. It's literally just removing an iodine. So both of them bind to their target cells, but T3 is 10 times more active than T4. So again, if we have T4 circulating, we remove one of the iodines, it becomes T3 has a stronger affinity. All right, so what else is there? Negative feedback mechanism, that makes sense, right? We turn it off when we think about it, controls the metabolism of every single cell. So negative feedback mechanism is a big deal. That's there. There is hypothalamic thyrotropin releasing hormone, and that is at TRH, and that's important too, because again, it has a feedback mechanism, but we can overcome that because when a woman is pregnant, then of course we definitely need for her to do that. So overcomes the negative feedback during pregnancy or exposure to the cold, and this is especially in infants. And so that means that we allow, right, the metabolic processes of the cells to continue, especially in females, because that whole idea about eating for 2, you don't really double all your calories or things like that, but you do need more things, obviously, to nourish the infant that's growing inside of you. All right, so here again are just the effects of T3 and T4. So I'm not joking. Like when I say nearly almost every single cell in the body, if you look at this is the basal metabolic rate, which helps with your body temperature, which, as you guys know, increased body temperature increases reactions, decreased body temperature decreases reactions. This is your carbohydrate, lipid, and protein metabolism. That's like the food that you eat. There you go. Nervous system, cardiovascular system, muscular system, skeletal system, gastrointestinal system, reproductive system, integumentary system. So when I tell you the thyroid hormone, right, has an effect on almost every single cell in the body, it is really, really important, really important. So here we are with hyposecretion, right? So hyposecretion of thyroid hormone in adults can lead to this myxedema or myxedema. And so the symptoms, low metabolic rate, right? Thick, dry skin, puffy eyes, feeling cold all the time, constipated, edema, mental sluggishness, lethargic, that. And if it's due to a lack of iodine, which I mentioned before, right? That's a goiter. And that goiter, of course, is going to be seen as an enlarged thyroid. And I think they show a picture. Yes. So there is a person right there with a goiter, right? Iodine deficiency. Hyposecretion of the thyroid hormone can lead to creatism, and this is bad. This could lead to like really bad mental retardation. So intellectual disabilities, short and disproportionate body size, a very thick tongue or a thick neck. So hyposecretion, of course, is problematic as well. So we closely regulate thyroid hormone, right, through negative feedback mechanisms. And then, like I said, there she is with a goiter. Hypersecretion, we see that in Graves' disease, and Graves' disease is classified as autoimmune disease. So you have antibodies, remember autoimmune disease, because we just finished the immune system. You have antibodies, and those antibodies mimic thyroid stimulating hormone. So if I have an antibody that is mimicking thyroid stimulating hormone, what does thyroid stimulating hormone do? It stimulates the thyroid to release thyroid hormone. Yeah. So elevated metabolic rate, rapid irregular heartbeats. Remember, it's increasing the metabolism of everything. Nervousness, you know, severe weight loss, those type of things. And it can cause the eyes to protrude. Like former First Lady Barbara Bush, right? So that's the first Georges. Is he W? I forget them. But anyway, Barbara Bush is, had Graves' disease, All right. So hypersecretion, Graves' disease. Okay, so the treatment, because you have a hyperactive thyroid gland that's caused by antibodies that mimic thyroid stimulating hormone, which means the only thing you can do at this point, because it is an autoimmune disease and the antibodies are produced, you kind of like surgically remove the thyroid. Or radiation. Radioactive iodine. Yep. So radioactive iodine will destroy the active thyroid cells. Isn't that crazy? Radiation. Okay. And this is that exophthalmos, that's the bulging eyes, Graves' disease. All right, so calcitonin, I told you didn't have to know that this came from the parafollicular cells, because thyroid hormone comes from the follicle cells. This comes from the don't know that, but it is antagonistic to parathyroid hormone gland. So, or parathyroid hormone. So parathyroid hormone increased blood glucose, which means then calcitonin would bring down blood calcium. I said glucose, sorry. Calcium. So it inhibits osteoclast activity. So remember I told you with parathyroid hormone, it sends the signals to the osteoclast. Osteoclast destroy the bone's matrix, right? Takes the calcium and transcytoses it into the blood and brings blood calcium levels up. And then this is calcitonin, which has an antagonistic effect to parathyroid hormone, which means it brings calcium levels down. Okay? And then they just show you again the follicular cells versus the parafollicular cells. All right, let's see what else is there. Well, that's it. That's thyroid. So we talked about calcitonin and we talked about thyroid hormone being released from the thyroid gland. Now we move to the parathyroid gland. Parathyroid gland releases parathyroid hormone. We've already talked about it. Parathyroid hormone is one of the most important hormones as far as calcium regulation. It's a big deal. So we already know what it does. It's going to be secreted in response to low calcium. That means a humoral stimuli. Remember, it's in the blood, so low blood calcium levels. Let's see, targets the skeleton, the kidneys, and the intestine, because that does help with the reabsorption of calcium and the kidneys, right? And so parathyroid gland are located on the dorsal aspect, right, of the thyroid gland. So you know you're looking at the back of this when you can't see the isthmus. Anyway, so, and they are in pairs, so that's the parathyroid gland. And again, oh, see, here's the specificity of it. Stimulates the osteoclast to degrade the bone's matrix so that they can release the calcium and transcytose it to the blood. Yay, that's what it does. Now, promotes the activation of vitamin D by the kidneys. Yes, kidneys help. Why? Because vitamin D helps with the absorption of calcium. Almost always, if a person is experiencing things like osteoporosis, for example, then they would have to take vitamin D and calcium supplements. Very rarely would you just be on calcium and not vitamin D, okay? So vitamin D helps with the absorption of calcium. All right. So all this is telling you what that blood signal is, right? So humoral, like we talked about earlier. Hypocalcemia is decreased blood calcium, stimulates the release of parathyroid hormone from the parathyroid gland, and then these are the effects. Osteoclasts are going to break down the bone and put calcium into the blood. Then we have effect on the kidneys themselves with the reabsorption of calcium. That means calcium stays into the system, right? And then we have the activation of vitamin D, right? And the vitamin D helps with the reabsorption of the calcium. And so that is why the intestine is down there, because vitamin D is going to help with the reabsorption of calcium, and it's your small intestine that's responsible for absorption, which we'll get into when we get to the digestive system. All right, so hyperparathyroidism means it's overactive, right? And that's usually due to a parathyroid tumor. Calcium leaches from bones, causes the bones to be very soft and deformed. Elevated calcium depresses the nervous system. And then we have this osteitis fibrosis cystica, which is a severe form of having like weak bones, and they fracture extremely easy. So that's a bit of a problem. Hypoparathyroidism, following some type of gland trauma or the removal of the gland, could lead to hypocalcemia. And since we need calcium for, you know, contraction of smooth muscle and skeletal muscle and even nervous system impulses, tetany, respiration paralysis, and even death can occur. Yeah. Okay. So let's see the adrenal gland. Now, so this one is the one that I said that you definitely have to know if it comes from the adrenal cortex or if it comes from the adrenal medulla. So of course they have the adrenal medulla here, which is sympathetic nervous system, and we are aware of that. So adrenal cortex is the outside, right? It's 3 layers of glandular tissue there, and they do secrete different hormones. Yeah, we're going to get to them. Look. So when we talk about the cortex, which is that outside part, we have the mineralocorticoids, and we have the glucocorticoids, and we have the gonatocorticoids. I've already spoiled it for you because these are the 3 different zones, and you don't have to know those for me. Like, I'm not going to be that specific. But I do need you to know that aldosterone is quite important, and it is one of the mineralocorticoids. So mineralocorticoids primarily regulate your electrolytes, and aldosterone is the most potent mineralocorticoid we have. And what does aldosterone do? Well, aldosterone is going to stimulate the reabsorption of sodium. Now, why does the reabsorption of sodium have any effect whatsoever on potassium? And I know you know the answer, because I am sure that you know that sodium and potassium are antiported, which means if sodium is going in, then potassium is going out. And I know you know that when sodium flows into the cell, that the cell is going to be depolarized. And if potassium, and this is by themselves, this is not through sodium potassium ion channels, but just potassium leaving a cell can cause the cell to be hyperpolarized, and hyperpolarizations lead to inhibitions, which can lead to things like cardiac arrest. Yeah, so aldosterone helps with potassium being eliminated in the urine, like through the kidneys, because if potassium stays in high concentration outside of cells, because remember, it is the major intracellular cation. If it stays in high concentration outside of cells, it's problematic. So we're like, oh, nope, get rid of it. And so we allow it to go and be released in the urine. Yep, isn't that cool? So reabsorption of sodium, elimination of potassium, they go in opposite directions. And that's a big deal. Oh, such a big deal. All right, what else is there? I love this crap. I know you guys know that. All right, so let's see. Sorry, I'm trying to get my clicker to go to the next page. There we go. All right, so mineralocorticoids, right? The effects of aldosterone are short-lived. There is that sodium-potassium pump, which of course is run by ATP, so energy is needed for that. Other factors that regulate aldosterone secretion, ANP, adrenocorticotropic hormone, plasma concentrations of potassium, that's extracellular, that means it's outside of the cell if it's in the blood, and then this renin, angiotensin, aldosterone mechanism, which we know about already because we talked about it in the control of blood pressure. And we'll talk about it again when we get into the renal lectures. All right, so let's see. There's a renin, angiotensin, aldosterone mechanism, and it can decrease blood pressure. What? Causes the release of renin, and then that renin stimulates the angiotensin. Angiotensin 1 is going to become angiotensin 2, and angiotensin 2 happens to be a very strong, you guys ready? Vasoconstrictor. And obviously, if I'm vasoconstricting, I've got to work harder to get the blood through the vessels, which means it's going to increase my blood pressure. Okay, sorry. Anyway, let's see what else is there. I just get so excited. All right, so let's see the plasma concentration. So again, I already told you that if I have an increased amount of potassium in the plasma, so in my blood, that can be problematic, right? And it can lead to inhibition. So we want to get rid of that potassium that's there. So if sodium is being reabsorbed, then potassium is going to be eliminated through the kidneys. Thank you, kidneys. And then we have the adrenocorticotropic hormone, and that can cause small increases of aldosterone during periods of stress. And we talked about that earlier when they put stressors, right? And then you have ANP. ANP is the only hormone that's released that we've talked about that can actually lower blood pressure. All the rest of them increase it. So it's secreted by the heart. Atrial means it's coming from the atria, secreted by the heart in response to high blood pressure. And look what it does. It blocks the renin aldosterone secretion, right? Because renin, angiotensin 2, aldosterone, those increase, right? So it blocks that and it will decrease your blood pressure. It's the only one, don't forget it. All right, and then there's a nice little regulator of, aldosterone. It is major corticotropic hormone, so make sure you remember that, the mineralocorticoids. All right, so aldosteronism is hypersecretion, usually some type of adrenal, right? So kidney tumor, that's there. There's some major problems with that. Hypertension, yep, high blood pressure, and edema, because you got excessive amount of sodium that's being reabsorbed. You hold on to sodium, you hold on to water. And then this, the excretion of that potassium leading to abnormal and non-responsive neurons and muscle cells. You know, when potassium is in high concentration outside of the cell, it can cause inhibition, non-responsive. Non-responsive muscle, like the heart muscle, cardiac arrest. Just put that out there. All right, then we're going to move to the glucocorticoids, and surely this has something to do with glucose. What? No way. Anyway, so these maintain your blood glucose. What? Keeps them relatively constant. What? Who knew? Anyway, we have glucocorticoid hormones that include cortisol, which you've probably heard of, because cortisol is pretty effective, and they market our able to control cortisol for people who are trying to lose weight, right? So we market that. So cortisone, cortisol, and corticosterone, right? So these are major examples of glucocorticoids. And again, this helps keep blood glucose levels relatively constant. Well, it says cortisol can be released in response to ACTH, which we know is released in response to stress. Stress. I wonder if stress has anything to do with people who gain weight, you know, if they're under stress and they eat. Okay, anyway, of course it does. Anyway, and they market it as such. So cortisol secretion cycles are governed by patterns of eating and activity, right? So if cortisol is released in response to adrenocorticotropic hormone, and adrenocorticotropic hormone can be released in times of stress, then of course this has to do with your eating and other activities. What? No way. So acute stress, like infection, physical trauma, or emotional trauma, interrupts your normal cortisol rhythms. And so, yes, this plays a role in controlling your weight. And they know that. So this is scientific, neurologically proven, and as a result of that, highly marketed as ways to help control your weight. Okay? And that's all you need to know from me for right now. All right. So this is the action, right? So we already said that it plays a role in help maintaining blood glucose levels. So it says cortisol can increase in blood levels of glucose, fatty acids, and amino acids. This gluconeogenesis is making more glucose. So literally neo, like new, genesis, new. So making, so the beginning, this is making more glucose. And this again is to increase the blood glucose levels. And then other functions that cortisol can have is that it can enhance vasoconstriction. And of course, that would make your blood pressure increase. All right, so what else is there that we need to know? Excessive levels could depress cartilage and bone formation, so too much is a problem. Could depress your immune system, so again, that's a problem. And then this whole thing about disrupting cardiovascular, neural, and gastrointestinal functions, yeah, so it's, you know, it's glucose, right? It can be a problem. Glucocorticoid drugs can control many symptoms of inflammatory diseases, arthritis, and allergies, but you get undesirable effects as a result of that. And these would be those undesirable effects. And I know you guys know that we give people cortical drugs, right? And we do that in instances when they have like a hyperactive immune system, or they're having some type of hyperactivity, you know, in a response. And this, of course, since it depresses or, you know, inhibits the immune system, that would be the reason why we would give them that, to dampen it down. There are some people who have had like severe bronchitis, for example, and they were given steroid hormones. I think you guys know this, like prednisone, right? And that kind of decreases inflammation. That kind of you see what I'm saying? Brings those things down. So when you have bronchitis, right, that inflammation of the bronchioles is usually due to some type of infection, but we want to decrease the inflammation to make breathing easier for you, so we give you steroid drugs, like in this case. And these are steroid too, because these come from the cortex, which we mentioned earlier. But yeah, they could have some negative effects to that. But if your problem is that you have too much inflammation, right, then we'll give you the steroid drug to help control the inflammation and suppress the immunological response, which, as you guys know, inflammation is a positive chemotaxic, so it keeps going in that direction. And it does play a role in your immune system. Like inflammation is supposed to happen when we're trying to take care of infections. When we get a hypersecretion of cortisol, then again, this is problems with bone and cartilage formation, inhibits inflammation. So remember I told you that if you are experiencing inflammation, we could give you, right, cortisol or some type of steroid drug like prednisone. But if you are making too much of it, again, it becomes a problem. So usually it happens if you have tumors, the pituitary tumors or lung or the pancreas or the kidneys or all that, or the use of those steroid drugs that I just mentioned earlier, right? And if it's caused by overuse of the drugs, then of course we take you off the drugs. So if it's caused by tumors in these areas, then we need to remove the tumor. So discontinuation of drugs if it was the drug's effect that was causing the problem, but if it's a tumor, then we have to remove the tumor. All right, hyposecretion is what we see in Addison's disease, so decrease in glucose and sodium levels, so lose weight, severe dehydration, and hypotension, right, because I'm losing sodium. And of course, we give them the steroid drugs, right? We replace them. So we put them on the steroid drugs. So yeah, that's what happens. This right here is Cushing's syndrome. So this little hump, they call it the buffalo hump that you see, it's fat actually. Isn't that crazy? This was her before the onset of Cushing's, and this is her after the onset of Cushing's. So, all right. And then we go to the gonatocorticoids, so gonads, right? Weak androgens, which come from males, converted to testosterone in the tissues, and some can be converted to estrogen as well. I think you guys know that men do have estrogen, can contribute to the onset of puberty and the appearance of secondary sex characteristics, sex drive in women, and then a source of estrogen in postmenopausal women, because postmenopausal women have a decrease of estrogen. So the adrenal sex hormones or gonatocorticoids can actually help a little, right, with that lack of estrogen. And then hypersecretion of gonatocorticoids for men, it just makes a manly man. So if you're a young boy, then you just are a manly young boy. So you may have, you know, I don't know, a beard and a mustache at 9 years old, and you may be, you know, just well developed as a young boy. So in adult men, it's, you know, not even noticeable because it's a manly man. But if you are a female, if you are a female, it could cause your clitoris to look like a penis. It could cause you to grow a beard or chest hair. And so if you're a female and you didn't want to be a man, then hypersecretion of the gonatocorticoids is a bit of a problem. If you are a male and you love your masculinity, then you are a manly man. And that's a good thing. Boys, just early, just 9-year-old little boys looking like men. See, early onset. Men, don't even know. Manly man, it's if you're an adult male. But females with beards and chest hair and a clitoris that looks like a penis may not be what she wanted. Just saying. All right, the adrenal medulla, adrenaline, right? So this is our epinephrine, which is adrenaline, or norepinephrine, which is noradrenaline. These are classified as catecholamines. And so the effects of catecholamines are vasoconstrictors. What? Increase blood pressure. So they increase the heart rate. They cause vasoconstriction, which would increase blood pressure, increase blood glucose levels. What? Prepare me for fight or flight. Blood's diverted to the brain and to the heart and the skeletal muscle, you know, like when I don't know, maybe doing something like cardiovascular exercise, for example. Anyway, let's see, epinephrine and norepinephrine, or adrenaline and noradrenaline, basically have the same effects on the tissue. Epinephrine is more of a stimulator of metabolic activities, and norepinephrine more has an influence on the vasoconstriction and blood pressure, but basically pretty similar. The responses to stressors are brief, unlike the adrenocortical hormones. And FYI, these are water soluble, right? Adrenaline, epinephrine, those are water soluble, but the cortical hormones were steroids, longer effect. All right, and then just short-term versus long-term. So short-term effects, heart rate increases, blood rate increases. What things I never knew happened with adrenaline. Anyway, what? Adrenal medulla? Anyway, so let's see, you're going to get more glucose in the blood. We know that as well. Blood flow changes. No way. Metabolic rates and changes. So sympathetic nervous system. And then over here, we have the cortical hormones, right? The ones that are released from the adrenal cortex. So long-term responses. And of course, they're going to talk about the renin, angiotensin, aldosterone, right? So helps with water and sodium and blood pressure and blood volume and all that stuff. And blood glucose levels also increase because remember, we have the glucocorticoids that are in there as well. And then, of course, that's just the comparison short-term and long-term. So hyposecretion of adrenaline is not really a problem. You know why? Because adrenaline is not essential for life. So too little adrenaline is not really a problem. But too much adrenaline can kill you. Sure can. It can kill you. Because if you have a hypersecretion, this is uncontrolled sympathetic nervous system. Hyperglycemia high blood glucose, increased metabolic rate, rapid heartbeat, palpitations, hypertension, intense nervous system. Yeah, this could kill you. I'm not going to die. I'm not going to die. Sorry, I am going to die eventually. I'm not going to lie. Hypersecretion is problematic. Hyposecretion not, because it's not essential to life. Now here's a list of the adrenal gland hormones, and these are, of course, the ones that are cortex versus medulla, and that matters. So all of the other ones, like the pancreas, and we talk about insulin and glucagon, which is probably coming up soon, that doesn't matter to me where, right? Those are produced, which cells produce those. And same thing with the thyroid gland. I don't care if it's the follicular cells, which is where we're actually going to get the thyroid hormone, or calcitonin, which comes from the parafollicular cells. That doesn't matter to me. What matters to me about specificity of the gland is the adrenal gland. Adrenal medulla is where we get our epinephrine and norepinephrine, and the adrenal cortex is where we get our cortical hormones, okay? So cortex, cortical, it's in the name. All right, so what do we need to know about the pineal gland? Pineal gland secretes melatonin. Well, what does melatonin do? Well, sexual maturity and puberty, day and night cycles, you know, because we're diurnal creatures. We stay up during the day and we sleep at night. For those of you who work midnights and you're trying to sleep during the day, blackout curtains, right? Trick your mind into believing that it's nighttime, because melatonin is secreted in the dark cycle. Anyway, so let's see, body temperature, sleep, appetite, antioxidants, which detoxify, right? Things, you know how antioxidants work. So the pineal gland secretes melatonin. You need to know that. Here we are with the pancreas, and they're going to tell you specific cells of the pancreas that produce glucagon and insulin, and I don't care about that, but I do need to know, I do need you to know that if you are hyperglycemic, it's because you have excess glucose in your body. And so glucagon is the hyperglycemic hormone. It's the one that makes you increase your blood glucose. And then insulin is a hypoglycemic hormone. Insulin brings down blood glucose levels. Now, when are they secreted? They're secreted, glucagon is secreted when you are hypoglycemic, and insulin is secreted when you are hyperglycemic. So they're just telling you what they do: increase blood glucose, decrease blood glucose, but they're released in response to either high or low blood glucose levels. So again, you don't have to know exactly which ones. So here we are. Glucagon, right? It's going to increase your blood glucose. So it breaks down glycogen, which is a polymer of glucose, right, into glucose. We do that. Can synthesize new glucose. So I gave you this term earlier when they mentioned it. Gluconeogenesis is making new glucose, right? So glucagon increases your blood glucose levels. Insulin does what? Decreases blood glucose levels. When is it secreted? When your blood glucose levels are high. So for test purposes, in lecture and in lab, if I'm to ask you what the function of insulin is, you can't tell me that it regulates blood glucose. That cannot be your answer, because guess what? Glucagon also regulates blood glucose. And you can't say, oh, has an effect on blood glucose levels, because glucocorticoids have a role in that as well, and adrenaline has a role in that. So you have to be specific. If I ask you what the function of insulin is, you must tell me that it decreases blood glucose levels. And if I ask you what the function of glucagon is, you must tell me that it increases blood glucose levels. You can't just tell me it regulates blood glucose, because other things regulate blood glucose levels. Even growth hormone plays a role in glucose, remember? So I'm there. Ooh, don't play with me, y'all. Don't play with me. All right, so let's see. What else do I need you to know about insulin? I don't need you to know this other stuff. It's kind of cool, though. We talked about the tyrosine kinase. Remember that autophosphorylation that took place when we were talking about second messenger systems and stuff? Anyway, so that's, you know, kind of a cool thing that insulin does. SE polymerizes glucose to glycogen. So that means I take the glucose and build it into glycogen. It's going to bring my glucose levels down. Let's see, factors that influence insulin release. Again, your glucose levels are going to do that if they're high, right? Glucose levels. And then, of course, other hormones that play a role, which is what I just said a few minutes ago, how you can't tell me that it just regulates blood glucose levels, because glucagon, epinephrine, growth hormone, thyroxine, and glucocorticoids also play a role in glucose levels. So no, you can't just tell me that. All right. And then I just tell you how, if your blood glucose levels are out of balance, too high or too low, how we'll stimulate the pancreas to release insulin when it's too high, or stimulate the pancreas to release glucagon when it's too low. All right. And then some, homeostatic imbalances. Hyposecretion of insulin happens in type 1 diabetes. Hypoactivity of insulin is what we see in type 2 diabetes. We also, of course, see an increase in glucose levels during fight or flight. We know that. If your blood glucose levels are too high, it spills over into your urine. We'll talk about the TM, which is the saturation maximum, so the total amount of a certain substance you can have in your body. If it goes above the maximum in the blood, then it'll spill over into the urine. So that's glycoluria. So we see glucose in urine, right? You can do the dipstick test and see that in there. And then polyuria, terminology, excess urination. Polydipsia, you're extremely thirsty. Polyphagia is you're extremely hungry, okay? Let's see. I think most people know that ketones are a product of fat metabolism. So people who are on the keto diet, right? You can test for ketone bodies in your urine, and so that means that you are in ketosis. This, of course, it's pretty controversial, right? Because it could be dangerous with ketosis, right? Acid could build up and cause problems whenever you have a change in your blood acidity, especially if it becomes more acidic. It can lead to things like cardiac arrest. Again, you may have heard this already. So disrupted heart activity, that's where some of the concerns come with the keto diet. And I think you guys are, you don't live under a rock. So you've probably heard of people that are on keto diets. Hyperinsulinemia, excessive insulin, caused by hypoglycemia, so low blood glucose levels, anxiety, nervousness, disorientation. You can even die, like no lie from that. And so you give the person, sugar really quickly to bring their blood glucose levels up. And then this is just insulin and how it works with other cells. Type 2 diabetes, and I'll just explain it to people. So type 2 diabetes, remember adipocytes have the ability to release hormones. And lecithin is one of those hormones that is released by adipocytes, so by fat cells. And lecithin actually has a negative or an opposing fact on insulin. So blood glucose levels increase. And so there are people who have the onset of type 2 diabetes because they have a lot of fat cells, right? So they have gained a lot of weight, and you can actually acquire diabetes through that. Isn't that interesting? All right. And then we have estrogen and progesterone, right? So the ovaries secrete this. And for females, maturation and reproductive organs, right? So our eggs are there. The appearance of secondary sexual characteristics, progesterone, get the breast development that's there, and changes in the uterine mucosa. And then for testosterone, this is men, right? So testosterone helps with the maturation and the production of their male organs. Secondary sex characteristics and even the sex drive is regulated by testosterone. Maintains normal development, so spermatogenesis, normal sperm development, is dependent upon testosterone, which we talked about earlier with the luteinizing hormone and the follicle stimulating hormone. Luteinizing hormone actually aids in the production of testosterone, and testosterone is needed for spermatogenesis. So luteinizing hormone, if it's decreased in males, could be considered sterile. And then the placenta secretes estrogens and progesterone and the human chorionic gonadotropin hormone. So beta HCG is what we test for in the blood or in the urine to do pregnancy tests. FYI, if a male has a positive pregnancy test, and I know it sounds weird because like how many men would take pregnancy tests, right? But if they have a positive pregnancy test, it could be an indication of testicular cancer. That's just an FYI that I like to throw out there for people. Oh, there we go. Leptin. Okay, so adipose tissue can release can release hormones as well. So this leptin, I think I called it lecithin, but leptin, this is the one that contributes to their increased chance of actually developing Nope, it's resistin. See, I've got to give my hormones. So resistin is the insulin antagonist. So lots of adipose cells, and then they have the resistin, and the resistin goes against insulin. So people with type 2 diabetes could actually develop it because of their obesity. And then none of these will be on this test. So these are the ones secreted by the gastrointestinal system. And the reason why I don't put these on this test is because we'll talk about them on the digestive system. And the digestive system is going to be with, what is digestive system? With respiratory, maybe? No, this is endocrine and immunity. Yeah, so digestive system and respiratory, I think, go together. But anyway, we will talk about these, how important gastrin is, which stimulates the release of hydrochloric acid, and the role of hydrochloric acid in protein breakdown, right, in the gastric phase. We'll talk about secretin, and then we'll talk about CCK and the important role that CCK plays in there. And so, yeah, but we'll talk about all of these in the digestive system lecture. We've already talked about the heart and the fact that it releases ANP. This is the only one that decreases blood pressure, and we know that. We also know that the kidneys release erythropoietin. We know that because we talked about that in the blood lecture. Erythropoietin means I'm going to signal red blood cells to be made, right? And then we also know that the kidneys release renin, and it's part of this renin angiotensin 2 aldosterone mechanism, which increases your blood pressure. And then osteoblasts, these are cells, they release osteocalcin. And so this can play a role in the secretion of insulin and in handling glucose properly, so activated by insulin. And if you had me for 2085, we talked about that for just a second, and its role with blood and glucose. And then the skin produces this calcitriol, which is a precursor to vitamin D. So remember when we said that UV has to absorb through the skin in order for you to synthesize vitamin D. This is the precursor. And without the precursor, we won't get vitamin D. Calcitriol is the active form of vitamin D, and that helps with, of course, the absorption of calcium in the intestine. Talked about that today as well. And then the thymus does secrete hormones, but remember what the thymus is concerned about? One thing and one thing only, the development of T cells. That's it. So the thymus is a gland, and the thymus does secrete hormones, but these hormones act as paracrines. They're very specific on the cells that they react on, and it's in the localized area. Because the T cells, of course, go to the thymus to mature, and the thymus secretes the hormones that act on the T cells specifically. That's all they care about. T cell, T cell, T cell. And then I don't test on developmental stuff, but we have some glands, right, that won't start releasing the hormones until we reach like puberty, for example, like your sex hormones. It's functional throughout your entire life, but then it kind of wanes down. So growth level hormones decline. We already know that the thymus atrophies, so that means that those levels are going to decline as well. Let's see, glucose tolerance deteriorates with age. Ovaries undergo significant changes as you get older, and even testosterone. But men, as long as men are living, they could potentially make babies. Just putting it out there. All right, ladies and gentlemen, that is the end of